All right, today we're going to do something a little different. We are going to take a journey right inside the mind of a clinician to see how they work. We're going to break down step by step exactly how they diagnose one of the most common surgical problems out there, a hernia. We're going to follow the trail of clues right from that first complaint all the way to the final diagnosis.
So, here's the game plan for our diagnostic journey. We'll kick things off by defining the problem. What exactly is a hernia? Then, we'll start gathering clues from the patient's story and a hands-on exam. After that, we'll look at a few special tests to really pinpoint the issue before we finally classify the different types of hernias and their potential risks.
Okay, first things first. Before we can even think about finding a hernia, we have to be absolutely clear on what it is we're looking for. So, what is the fundamental problem we're dealing with here? When you boil it all down, a hernia is actually pretty simple. Something is just not where it's supposed to be. An organ, or what doctors call a viscus, and yeah, that's usually part of your intestine, has pushed its way through a weak spot in the muscle wall that's supposed to hold it in. The analogy on the screen is perfect. Think of it like an inner tube bulging through a weak spot in a tire. That's exactly what's happening. The very first clues we get often come from how the patient actually describes the pain. It's usually not that sharp, sudden pain you might expect. Instead, it often starts as this kind of dull, dragging ache, and it just gets worse as the day goes on. But here's the really, really important part, that last point. If that lump suddenly gets tender and it hurts to touch it, that's a huge red flag. It could mean a serious complication is developing and it's time to get help, like, right away. Okay, so now we get to what is honestly one of the most critical parts of any diagnosis, and it happens before the doctor even lays a hand on the patient. This is where the real detective work begins, carefully listening to the patient's story to gather every last clue. So imagine this. A patient walks in and just says, "Doc, I've got this lump." Right there, the investigation kicks off, and the answers to just a few specific questions are going to give us our first major leads and start pointing us in the right direction. So what do we ask? First off, you want to know how it started and where it first showed up. Why? Because that simple question helps distinguish between a hernia someone was born with versus one that developed over time. Next, you ask about its size. But honestly, the real million-dollar question is that last one. Does the lump disappear on its own when you lie down? If they say yes, man, that is a massive clue pointing us toward a very specific type called a direct inguinal hernia. Now, while the doctor is asking all these questions, they're also listening for alarm bells, the real red flags. And if a patient describes this nasty combination of things, this really intense wave-like stomach pain, they're vomiting, their belly is all bloated, and, well, nothing is moving through their system, that is a flat-out emergency. These signs point to a blocked bowel, and that requires immediate medical attention. Okay, history taken. Now it's time for the hands-on part, where we actually connect the story we just heard to the physical evidence. This is all about confirming what the patient's history has already suggested. And believe it or not, the entire physical exam for a hernia really boils down to looking for two key things. Just two. These are the classic must-find signs that tell you what you're dealing with. First up is the cough impulse. So the doctor will have the patient turn their head and give a good cough. What does that do? Well, it spikes the pressure inside the abdomen, and that pressure literally forces the hernia to bulge out. If you can see it or feel that little pop or impulse, boom, that's a huge confirmation. And the second big one is what we call reducibility. It sounds complicated, but it's super simple. Can you gently push the bulge back in? If you can, great. That's a reducible hernia, and it's usually uncomplicated. But if it's stuck, if it won't go back in, that's irreducible, and that's when we start to get a little bit more concerned. And check this out, because this is a really cool and important distinction you can literally feel with your hands. It all comes down to a couple of key landmarks on the pelvis. An inguinal hernia, that's going to be above the inguinal ligament. A femoral hernia, that one's below it. Just that simple difference in position tells a clinician exactly what kind of situation they're dealing with. All right, so at this point, we're pretty sure we've got a hernia. But we can do better than that. We can get even more specific with a few classic diagnostic tests that can pinpoint the hernia's exact origin. So this really brings us to the next big question, right? We see a lump, it bulges when they cough, maybe we can even push it back in, but where exactly is it coming from? The abdominal wall has a few potential weak spots, and there's a really clever test to figure out which one it is. And this is where it gets really cool. This test is it's so elegant. The examiner literally places 3 fingers over the 3 most likely exit points in the groin area. The index finger goes on the deep ring, that's where indirect hernias often start. The middle finger covers the superficial ring, related to direct hernias, and the ring finger sits over the femoral ring. Then the patient coughs, and bam! Whichever finger feels that impulse tells you exactly where the hernia is coming from. So simple, but so incredibly effective. Okay, so what if the hernia is stuck and won't go back in on its own? Well, there's a technique for that called taxis. And it's not just about brute force. You're not just shoving it back in. Look at that specific leg position on the slide. You flex, adduct, and internally rotate the thigh. Why? Because that specific maneuver is designed to relax the exact muscles and ligaments that form the opening the hernia is stuck in. Once everything is relaxed, a little bit of gentle pressure can often guide it right back home. And I have to stress the word gentle. You never, ever force this. Okay, so we've gathered all our evidence. The patient's story, the physical exam, our special tests, and now it's time to put it all together. We can finally classify the hernia and, most importantly, figure out just how serious this is. So to really get the classification, you have to know about this one little piece of anatomy called Hesselbach's triangle. Just think of it as a natural weak spot in the abdominal wall. Now, a direct inguinal hernia literally punches straight through the middle of this triangle. But an indirect one, it takes a more roundabout path, starting its journey just off to the side of this space. And this table right here, this is the payoff. It's where our whole diagnostic journey comes together. Look at the top, a reducible hernia. You can push it in, there's no blockage, blood supply is fine, all good. Step down to irreducible, now it's stuck, but hey, at least the bowel isn't blocked yet. Then you get to obstructed, now it's stuck and it's causing a blockage, but the blood is still flowing. And then you get to the bottom, strangulated. It's stuck, it's blocked, and the crucial part, the blood supply has been cut off. That right there is a true surgical emergency. And that right there is really the whole point of this. This isn't just some academic exercise. Understanding all these signs, from the way the patient describes the pain to what the doctor feels with their hands, that's what makes the difference. It's what allows a clinician to tell a simple, routine problem from a life-threatening emergency. It's a journey of clues that can, quite literally, make all the difference.